Welcome back, everyone. I know that was a short break, but we want to go ahead and get started with our employer panel. My name is Christan Royer. I'm the Director of Benefits at Indiana University, as well as the Chair of the Forum. At IU, I manage employee benefit programs and help lead university-wide human resource initiatives. So these topics are really important to me. I'm happy to be moderating our next panel discussion, all about employers using price and quality transparency to purchase health care. We'll be discussing how some employers are using that price and quality information to purchase healthcare for their specific organizations. So before we get started, I want to do a couple quick introductions of our panel. If you don't mind to advance us to the next slide, please. Perfect. I would like to thank all of our panelists for being here today. I'm going to give a little bit of brief introduction, and then what I want to do is let them talk a little bit about each of their organizations and what they're doing. Up first, we'll have Phil Terry from Monarch Beverage, as well as Natalie Roberts. She's Senior VP of Support at Monarch Beverage, but based in Indianapolis. Phil is the CEO of Monarch, and under his leadership, the company has been named Best Places to Work and Healthiest Employer. Natalie is Senior VP of Support at Monarch, and she has responsibility for the support divisions, including finance, human resources, government affairs. She's also been nationally recognized for her work in health and wellness. They are very concerned about the healthcare costs in their organization, and so I'm looking forward to hearing from them about what they're doing at Monarch Beverage. After they wrap up, I would like for them to turn it over to Candace Schaefer. Candace is the Senior Director of Benefits at Purdue University, where she oversees all aspects of benefits for their employees. She was awarded with the Employee Benefits News Benefits Leadership in Healthcare in 2018. So thank you to all three of you for being here today. Next slide, please. So you're probably seeing some of the headlines on this slide that you've seen as you've been looking at your news feed every single day. Today's headlines about healthcare are becoming more and more common. Many of the articles are focusing on the cost of healthcare for employers and their patients, which are their employees. With prices soaring, healthcare costs topping over $20,000 in premiums for family coverage in 2019 and growing from there, many employers are looking at ways to provide coverage for their employees that's based on both quality and cost. Next slide, please. So here on this slide, this is a chart, a graph from the Kaiser Family Foundation's annual survey of employer health plan premiums. And so speaking specifically of those premiums, you can see that this shows healthcare premiums paid by employees and the employer contribution. It's a growing trend over time, and as a total premium increases year over year, employers can't bear all of the premium increases. So you can see where in many cases, employees are paying more out of their paychecks for their premiums as well. These premiums don't include any deductibles or out-of-pocket costs that employees are also paying when they receive care. It's just the premium. So this growing trend is really important to employers to keep an eye on. It's really important as employers try to attract and retain employees to also look at what their employees are paying out of pocket. Next slide, please. So as we talk about what are employees paying out of pocket, that amount is growing over time. So here you can see that out-of-pocket spending and health spending grew at a higher overall rate than inflation and employee wages. So employers are spending more on healthcare, and they're not able to increase salary for workers. And we're seeing this across the country. So this isn't specific to just Indiana. It's a problem nationwide. Next slide, please. And looking at these national headlines, looking at this national survey data, again, across the country, you can see the theme is the same. Healthcare costs are taking up a larger portion of employer budgets. These costs are growing rapidly. It is not sustainable for employers or employees. And this is a huge impact to employer budgets. I feel like, from my experience, I feel like employers are losing options to sort of improvise and levers to pull to control costs. For example, years ago, high deductible plans were put into place, and that used to be the go-to for employers. But many employers have reached the limits on raising deductibles and out-of-pocket maximums, and employees can't afford to pay any more. So they're just employers are looking for new opportunities, as we've been discussing throughout the day today, to figure out how to save on healthcare costs but provide that quality care. Next slide, please. As I think about healthcare costs for my organization and from what we've discussed today, I think it's important to think about the fact that employers can't keep doing the same thing and expect different results. We have to look for ways to understand what else is available out there for employers to pull as a lever to control those costs. So with that in mind, what I want to do is turn it over to our panel and let them talk a little bit about what they're doing in their organization and explain to us what they've done to use RAND study data results in the past. And what else they're doing in terms of quality tools, transparency tools, what they're doing in their organization. And with that, I'd like to turn it over to Phil and Natalie to talk a little bit about Monarch's approach.
Great. Thank you. I think my video is turned off by the host.
And I've just sent you both a little, you should get a pop-up to start your video.
Great, thank you. So listen, thanks so much for allowing us to participate. If we could go to the next slide, please. Great. A little bit about Monarch Beverage. We're a beer wholesaler, which essentially means we buy beer in very large quantities, and we end up breaking it up into smaller quantities and selling it to bars, restaurants, and liquor stores. We also play a significant role in promoting the responsible consumption of our product with consumers. We're an Indiana company, operate only in Indiana. We have about 650 employees, and although they reside all over Indiana, most of them are focused in central Indiana. So what I would like to talk with you about in terms of our journey in dealing with the issues around healthcare is tell you a little bit about that history, tell you about some conclusions we've reached about healthcare and what we as employers can do about ensuring quality care for our employees and managing cost, and then perhaps most importantly about the philosophy we have about the importance of healthcare to our business. And then I'll turn it over to Natalie, who'll tell you the stuff you really want to hear about what actually it is we're doing. So if we could go to the next slide, please. This is the problem we face. It's been shown, I think, as well or better by others, but it's the ever escalating cost of healthcare, not just to our employees, but to us. And as Christina appropriately said, this is not sustainable. We cannot keep up these increases. We have to do a better job of managing this. So if we could go to the next slide. This is, I think, the key point that I wanted to make, and this is our philosophy. And our philosophy is this, that because we're in business, we are in the business of healthcare. This epiphany was forced on me about 15 years or so ago when Natalie came to me with a proposal about opening an on-site clinic. And, you know, I can recall that it wasn't very far into her presentation that I had reached an answer and gave it to her. It was a 2-word answer. The second word was no. The first word had 4 letters, And it did not start with H, meaning that this was repulsive to me. I didn't think that this was any part of what we do. What we do is sell beer. We're a logistics company. We move heavy products around the state, and we promote their responsible consumption. We're not in the healthcare business. But Natalie took me through her logic, which was simply just pulling out our financial statement and looking at where our costs were. We spend most of our expenses on buying the products we resell. That's obvious. The second one is the amount we spend on people. But the third one was healthcare. We spend more on healthcare today and then than we do on trucks, on fuel, on advertising. All our other expenses pale in comparison to the amount we spend on healthcare. So our point is that we spend a lot of time and attention and resources on acquiring the products we sell, on educating and training and promoting the people who are part of our company. We spend a lot of time and effort and resources on making sure we acquire the right equipment, the right fuel, that we're advertising our products responsibly and appropriately. But we spend very little time on healthcare. Very little of our attention was focused on it. And so her point was, and the epiphany that came to us, is that we are in the healthcare business and we should treat it as such. So because of that, we did put in the clinic. We have then and have today a clinic staffed with a physician, nurse practitioner, dietitian, physical therapy, and we adopted a number of other tactics to address healthcare, such as financial incentives. We have all the financial incentives you've ever heard about in terms of high deductibles, incentives for appropriate reviews of physicals and trying to direct behavior. We have free food. We have mass communications. We have targeted communications. I think we have employed every tactic anyone ever has to affect the health of their employee population as well as the cost. And we've seen a number of benefits from doing all that, not the least of which is improved employee morale. But there were a couple conclusions we reached that are driving our current tactics. The two conclusions we reached relate to behavior. If we could go to the next slide, please. And that is that there are a couple aspects of behavior of the people we work with that we have not been able to change. I'm going to do a little footnote here. This may be the most important thing I say, that the source that we've quoted here, the long fix from Dr. Lee, I would certainly recommend this to everybody. It's a very thoughtful and knowledgeable exploration of what all of us collectively do as healthcare providers, as employers, and as public policymakers to do to bend this trend on ever escalating healthcare costs. But the two behaviors we concluded we could not really impact are the habits of our employees, diet and exercise, and their choices regarding healthcare. Now, as to each of those, the habit around diet and exercise, I'm being a little too critical perhaps of that. I believe intuitively that we have made our employees behave more appropriately and more responsibly. It's just we haven't been able to prove it. The proxy we use to determine whether we're improving diet and exercise is BMI. And over the last few years, we have not seen an improvement in same life data on BMI. So I can't tell you that the proxy we're using is telling us that we're succeeding. I believe that we are, but I can't prove it. We have improved, though, things that relate to health interventions with our employees, such as blood pressure, A1Cs, and cholesterol, but not necessarily BMI. So I'm not sure we can change their behaviors. That's not to say we're going to quit trying. I'm just not sure we're able to do that. The other thing we concluded that we have not been able to succeed in doing is making our employees smarter consumers. In fact, I think Christian had talked about high deductible plans, and we still have them. I think they're going to become something we discard before long, because I think they not only don't make our employees better consumers, I think they make them worse consumers. The reason I say that, and this is based on anecdotal data, we have incidences of employees making poor health decisions because they have not yet met their deductible. They have avoided appropriate care because they know they've got this high deductible to pay and they haven't yet consumed it or spent it. Conversely, we have examples of where employees have overused services, healthcare services, because they have met the deductible. So I think that the high deductible plans create perverse incentives, both to those who have met their deductible and who haven't. And beyond that, for sure, we believe that we have not been able to make our employees acquire the knowledge necessary to be smart consumers. Not just what facilities they should go to, but what healthcare provider they should be requesting services of. So the conclusions we've reached are that we cannot affect the behaviors universally of our employees about their choices on habits or making them better consumers of healthcare. So what we have concluded is that to make that change, we have to get more involved in the decisions that they make around healthcare. We need to be more involved so that we help make them make the right decisions for them, to give them the best care, and to make sure that it's being provided to them at a reasonable rate. So let me turn this now over to Natalie, who will tell you what we're trying to do to help our people make better decisions. Natalie?
Thank you. If you can go to the next slide, please. So Phil did a great job of explaining what, how our philosophy has not changed in the fact that if we're in business, we're in the business of health. And kind of how the strategies that we've how the strategies that we've used to try to attack that have worked or haven't worked. One of the things that we've actually had a clinic on site that Phil mentioned that we've had as the baseline to try to help us with that, whether it be the free food, whether it be on-site healthcare or on-site fitness classes, all of those things that he mentioned, those are the lifestyle management types of approaches. The clinic has always been a constant. That is has been there, and we've had great success with that team. What has evolved is how we've used the on-site healthcare center. When we first started with the clinic, it was very transactional. It actually was managed by a health system, one of the larger health systems in town. And what we found was, and it worked, we were able to see real savings. It worked in terms of taking care of our employees. But as we evolved and wanted to move towards managing chronic diseases and really trying to prevent those types of diseases from happening, we evolved past what it was that health system could provide. And we started as of the first of the year managing that clinic ourselves, and we formed a separate entity called Well Health Works, and that is a separate company that operates as its own. And what that allowed us to do is really align strategy with our HR team. We do not have access to medical PHI, but it really allows us to align strategy so that we can have plan design that is very much so aligned with our medical team, and we can all work together to use some of the tools like the RAND study and the Quantros data. If you weren't able to participate in Shane Wilverton's presentation earlier today, I strongly urge you to go back and look at it and listen to the recording, because Quantros is a large piece of what our healthcare center is using. We'll talk about it in a few minutes, but they're using to, in conjunction with RAND, to put together scorecards in order to direct care. And it's really a large piece of how we're trying to do exactly what Phil was talking about, which is stop asking our employees to be good consumers of health and really being very paternalistic in saying, look, here is the data that shows these are the high performing providers at low costs, and this is where you need to go to consume your health. And here's the data that tells you that that's in fact the case. So if you could please go to the next slide. So really, that's where our philosophy is now. It's how do we use data and tools and resources so that we can help our employees navigate the system. Actually, we don't even ask them to navigate the system. We just say, please use the healthcare center. And we'll, if you have a condition that requires us to refer you outside of Well Health Works, just come to us and we will refer you to the high quality, low cost provider using the RAND study and Quantros data to not just send you to a center of excellence, but to what we call a physician of excellence. And that's really where we focused our 2020 goal. 2020 goal on is to this physician of excellence model. The other goal that we had is really, we had this fallacy of thinking that a tiered network would work and that our employees, if there was this differential in network and there was this 10% differential, and that our employees would actually care enough to get onto a tool or a website to say which one of those doctors would cost less, and whichever one of those doctors are, I'll go to it. And again, it was just kind of that same bad thought process of our employees just aren't good enough at navigating that tiered network. And so we're moving away from that and really trying to build a program and a plan design that says, okay, let's reward our employees based off of, again, that low cost, high quality provider using Quantros and RAND data. You could go to the next slide. So with this focus on disease prevention and disease management and quality providers and low costs, that's really where we formed, if you could go to the next slide, this partnership with iHigh. And that is really what has been very unique, because we can build these scorecards based off of Quantros telling us, okay, if this physician ranks in the top 10% nationwide for this clinical care category, that's great. And if RAND is telling us based off of the study that this hospital system, based off of that data, if that's part of the scorecard, that's all good and well. But if we're trying to focus on building programs for our disease management side, our chronic disease management side, we've never been able to do it in a way that is dealing with real-time data. All of our population health management data has always been based off of claims. And if anybody has ever tried to build programs on that, we know that that's 6 to 9 months old. And so what we were able to do with partnering with our health information exchange is they were able to use quality metrics that were real-time. Our health information exchange allowed us to give them the quality metrics that we were interested in looking at and say, okay, we will build you a pop health dashboard that is real time and tell you who your current A1C population is that is not controlled. And our Well Health Works team can then go out and build programs to try to actively manage those people. We're also able to build reports that our Well Health Works team gets every morning that tells them who was admitted into the hospital over the weekend for things like COVID or heart attacks. And then they're able to build utilization care coordination programs that helps with transition to care or seeking other low-cost, high-quality providers. And that then allows us to start to, if you could go to the next slide, start to look towards, and go ahead and go to the next slide beyond that, please. Start to look towards doing all of the things that we've heard about all day long, which is how do we work towards really getting into the next generation of building partnerships with those providers that are really making a difference and working towards high-performing networks and negotiating direct contracts. And really that last bullet point, shouldn't say reference-based pricing, but building contracts that are bundled pricing and working together with all of these levers, which is real-time data, these scorecards that show us RAND data, Quantros data, and then kind of pulling them all together. And then I think that's really what we'll finally kind of have the trifecta and go from there. So we're really excited about what 2021 can bring to the table with all these things. And our partnership with the Employers Forum has really been at the center, and we're very blessed to have the forum in our journey. And I think we'll turn it over to Candace from there.
Okay, thanks, Natalie. If we could go to the next slide. Oh, and the next one, sorry. So if you're not familiar with Purdue University, we're located in Indiana, of course. We're one of the nation's leading research institutions. We have 3 campuses and 4 locations. We also serve Purdue Global as part of our entire university as well. You can see we have just under 13,000 eligible employees, 25,000 total members. And currently in 2020, we have most of our members are enrolled in a high deductible health plan. But you'll see later we are moving in 2021 to be fully high deductible health plan, and we are getting rid of our PPO plan. So what we focus on in our benefit department is really we want to provide high quality, affordable, family-friendly benefits. Access is important, choice is important. We are in every county of Indiana because we are a land grant institution, and then we're in at least 20 other states. And so we have a wide variety of members who have different needs, different points in their life, and their family is in all different cycles of life. So, but another thing that we've been working towards the last 3 years or 4 has been around reshaping healthcare at Purdue and disrupting all the things that we feel needs to be disrupted in healthcare. So next slide, please. So I want to kind of give you guys some history on where we started, what we did, and kind of how we've moved into our current plan and our future. So you can see here on the graph is our history of total cost from 2014 through 2017. One point that's not on here is in 2013 on our main campus, where a majority of our members are affiliated with, we opened an on-site clinic in hopes of helping drive down costs, increase primary care utilization, make healthcare easier for our employees who are on the West Lafayette campus. And we also made a move to Anthem that year, and that brought us significant savings. And so for several years after that, we somewhat rode on those savings. But you can kind of see, it is hard because the graph doesn't really stretch it out very well, but you can really see that impact. We started to, in 2016, started to see that impact on costs were just going to keep going up. And moving forward into 2017, even though we started to make some changes and looking at our plan design, looking at our partnerships, we were quickly noticing that the savings we had received in 14 were not going to last very long. Next slide, please. So in 2018, in earnest, we really started looking at our data and what were we spending our money on, what was waste, what was excessive, what did we have the outcomes we were looking for, how were we managing everything as a whole. And so you'll see there on the left, Healthy Boiler is really a larger benefits initiative and campaign that we have. All of our benefits, workers' comp, leaves, family-friendly initiatives, health and wellness, mental health, and financial wellness all fit underneath there in those 5 pillars. But in regards to our physical health, we broke that into what you see in the middle, which we couch as a smarter healthcare. And we focus on 6 components that you see around the U, which is our member. And so we really want to make sure we can maintain some sort of access, help our employees navigate, because healthcare is complex and confusing. And one thing we really talk about internally is how it's so complex that at the point in which you need to understand it is also tends to be the point in which you don't have time to understand it. And so how do we create a program, a medical plan around meeting those needs at the time in which our employees or their family members need it? And so over the course of several years, we have done several things. Administratively, we've looked at all of our contracts. We've gone out for RFP, and we have moved vendors. When we renegotiate contracts, we throw in performance guarantees. We have fees at risk. We even looked internally to ensure that we were staffed properly and that we weren't being excessive in our expenditures. I'll skip over the bolded ones. We've also added concierge services, again, to help with that navigation of making healthcare less complex and trying to help steer folks to quality, low-cost options that make it easier for them when situations can be really difficult. And then we've also reviewed eligibility rules. And so we have implemented a working spouse premium, as well as we put in a future goal for 2021 in regards to our early retiree population. In many years from now, approximately 10 years, they will no longer be eligible to be on our plan. So it's not a short-term fix, but it certainly is something that will help keep the health plan healthy and thriving in the future. And then the 2 that I'm really going to focus on today are our narrow network option that we implemented, and then several of our direct agreements that we have implemented or in the process of implementing right now. Next slide, please. The first talk about is in 2020, we adopted the narrow network option Health Sync through Anthem, and we added it to all of our existing medical plans. And with this, we know that there are selected providers within the Anthem network that are focused on higher quality, low cost options. They're high performing. Our members can have quicker access. They also can have better access to specialists when they need that care, that additional care. And it was important to us that the network that's narrow is available in all of our counties across the state. And there are options. There are, of course, rural areas where it's healthcare normally there's some gaps there, but for our populations with our campuses, everyone has an option within the Health Sync network. Next slide, please. And so how we built it in is a 3-tier option, Health Sync being the lowest tier with the lower deductibles, low co-insurance, and out-of-pockets. And then it goes into the traditional in-network where we were in the prior year. And then, of course, we have out-of-network. So the downfall this year has been that as we were launching the Health Sync and really educating our population on how to use this network, what to think about, consider the relationship they have with their primary care provider. If they didn't have one, finding one within the Health Sync network. We were amidst COVID. And so we're excited to, as everybody is, to get out of that arena and really get back into helping drive folks to this narrow network and building those relationships with those higher quality providers. Next slide, please. So over the last 3 or 4 years, we have implemented several direct agreements. And the lighter ones are ones that are already implemented, and then I'll also share with you a couple that are in progress. Early on, we weren't as intentional around the first direct agreement, which was our labs. We have an on-campus employer clinic, and then we also have a student health clinic. And within those, there's a lab that's operated by the same operator, and having them on campus in 2 locations just made sense to us to go into a direct agreement with them, have negotiated prices that were lower than normal. And so all of our employees and our students would benefit from that cost savings. It also opened up the ability for our employees to go to the student health clinic lab in order to get labs. And so the student health clinic is actually on campus, where our employer clinic is on campus, but it's more on the outskirts of campus. And so it allowed folks to go get that lab work in the middle of the day, a little bit easier, more convenient for them. And then next slide, please. And our next one was imaging. And first, before we went into a larger imaging direct agreement, we also partnered with our student health clinic to provide basic x-rays on campus at the health clinic as well. And so that has been a great partnership. Again, easier access, very convenient for our employees and their families who are on campus on a regular basis. So you'll see as I walk through each of these, I'll explain to you why we decided that this was a good idea for our direct agreement, what pieces were we looking at and how we selected, and then if we're implemented, what kind of savings we believe we'll have. So imaging services are a commodity. We have a lot of volume every year. Our total plan is over 10 million annually. And so we also thought there was substantial competition. And so we knew we could drive with our volume and our cost, we could drive to a lower cost option. And so some of the criteria we looked at, again, access, the locations with everyone being spread out across the state, that was very important to us. But we also really wanted to look at quality. And so were they accredited? Was patient safety important to that operator? And then of course, cost is always a factor. You can't go without that. And we were able to find a partner in regards to imaging statewide, and we estimate about a 17% reduction in cost for that. Next slide, please. The next one that we implemented actually earlier this year was a total hip and total knee replacement. We had a really wide variety of costs. It was the same procedure for our employees all across the state. The range was anywhere from $30,000 to upwards of $95,000 per procedure, and with not necessarily the same outcome. And so a lot of times we talk about in here, you know, is it really about the cost? Is it really about the quality? And, you know, the answer of course is yes, it's a little bit of both. And, you know, we don't mind spending a little bit more if we know that the employee, their family member, is not going to have to go back and get another hip or another knee or any service that's out there. So as most employers, musculoskeletal expenses are very high for usually the top 3, if not the top. And you can see there just 75 procedures in 2018 and just over $2.5 million. And so given all of that, we really spent time looking at, well, how do you define quality? What do you look for? And so we looked at their qualifications, their experience. So were they known for hip and knee replacement? And have they been able and been successful at putting these bundles together? So the entire experience from pre-op to post-op. And then to that for post-op, were they successful in lower readmission, lower infection, quicker return to work efforts? And so all of that was considered. We also looked into and interviewed folks around patient care and what was that experience about. And so we were excited to announce that earlier in 2020. And we feel so passionate about that we've actually built an incentive program around that. And so when our employees and their family members utilize this partner for a hip or knee replacement, we pay their room and board around the surgery. Also, we do travel for them in the pre-op and to the actual surgery, as well as a cash incentive. And so we've already had a handful, even though given COVID, A lot of those elective surgeries were postponed. We have been able, now that things have opened back up, to have a couple of those replacement surgeries happen, and we're getting very positive reviews, not only on the experience, but also being appreciative of the incentive. Next slide, please. So a couple of them that we're currently in the midst of one is around our specialty prescriptions. And we first started with our specialty prescriptions within our medical plan. And we implemented that also in 2020. And we started with one drug in particular, and our partner in transitioning a small number of our employees. And we really kept a good watch on that. We really wanted to understand the employee or the family member's experience. We have spoken to many of them about their experience in order for us to understand what improvements or not improvements, or, because it's important to get a lot of that feedback from your members on what's going on, especially if you're trying to drive them to specific providers through these agreements. And so, but as other employers, specialty prescriptions are a hot topic. 1 to 2% of our volume is specialty, but it's over almost half of our prescription dollars that we spend every year for both employees and the university. We really wanted to look at the prior authorization process. We're concerned about outcomes and our members on the right drug in the right location with the right outcomes. That's very important to us. We had a lot of variances in site of care, and then looking at the copay assistance. And so can we maximize opportunities and spending for our employees? So again, similar criteria around this: provider qualifications, their experience, have they carved out both of medical and of prescription plans? And what was that like? How was the experience, not only for the member, but also in this case, what's been the experience on the administrator side? And so, we needed to know as a university what we were looking at in regards to day-to-day. Again, patient care, outcomes, and of course, cost. Next slide, please. Another one that we're in the middle of is physical therapy. Again, wide variation in cost. But with physical therapy, this was a little different. Not only are we looking at it from the medical plan standpoint, but also our workers' compensation. We have a really strong workers' compensation program and a return to work program. We're very proud of that program, but we still have room for improvement. And so how can we lower the cost around medical expenditures, but then also possibly lower our costs around workers' comp? And so again, qualifications and experience are very important. Experience with direct contract is important. We look at quality measures, and in physical therapy, it's the MIPS, patient experience, the ability to provide campus prevention services, and that gets at the workers' compensation. We have a wide variety at a university of jobs and roles, and many of our employees have a very physical job in our custodial, janitorial, maintenance areas. And so how can we have someone on site to help with prevention, or just be there when they get that first ache or pain, and helping them mitigate that immediately, that we think in the long run will help reduce their need for care, but then also reduce costs both out of their pocket and the university. Next slide. So this is my favorite slide now these days. And so what I've added here is before you saw 2014 to 2017 and that steady rise, even though we had significant changes or savings in 2014, but it didn't last very long. But again, in earnest, we started making changes in 2017 and 2018, and we really haven't stopped. And so you can see there, we had a really great year in 2018, and really it was just overall utilization. But you'll see from 17 to 19, and then what we project in 2020 and again in 2021 is essentially a flat trend. And so, everything, all the efforts, all the looking into the data, listening to our employees and their family members has really benefited us in being able to kind of bend the trend a bit for us, for the university. And you can see there in the totals that it's really not changing very much either for the employee out of pocket, their premium, or the university's expenses. Next slide. And here, this is just a summary of a lot of the different things that we've done every year from 2014 through 2020. And I think it's important to note that we review the data. We're constantly going back and looking again and re-looking and analyzing and measuring. But since 2017, we've never stopped doing something every year. But we are excited to say that starting in 2020 and then again in 2021, we will not be having employee premium increases. And yet we're still able to keep that trend flat. Next slide.
Awesome. Thank you, Candace. And also thank you to both Phil and Natalie. I really appreciate all of you providing examples of some of the strategies that your organization has implemented to control costs, to look at transparency, to direct employees to that high quality care. Before we begin taking a couple questions from the audience, I wanted to sort of recognize that I saw a lot of the questions coming in, and you know, not every strategy will work for every employer. I think it really depends on your size, your location, the demographics of your population, but these just really give us a couple of examples of what other employers are doing, specifically in Indiana, using some of that RAND study data and some of the other tools that we've talked about today. You know, we've heard Candace talking about tiered and narrow networks. We heard Phil and Natalie talking about on-site clinics. And I think it's important for employers to look at what actions they can consider as they're thinking about some of these strategies. There's clearly some benefit design strategies you can put in place. You can do reference-based pricing. You can do centers of excellence where you're directing care to certain organizations and providers. You can look at those value-based options and build those into your benefit design. So there are things that you can do just on the benefit side. And then of course, when you're looking at the provider side, doing some of those tiered or narrow networks, those direct contracting, trying to work, we heard earlier in the executive provider panel about, you know, would some of these providers be willing to do Medicare Plus contracting? And the answer was yes. So, you know, I think that there are different strategies that employers could consider. And I appreciate you all today talking about the different actions that you're doing within your organization. As I mentioned, we had a lot of questions come in. I tried to respond to some of them as they were coming up, but I had a couple for you all. Natalie, I think one of the questions that I wanted to ask you was, what are your views on programs that motivate employees with incentives for finding low cost, high value healthcare choices? How do you feel about that, and kind of talk through that for us?
Well, I mean, I really think the most effective thing that it's going to take is through plan design. I really do. And in terms of, you know, throwing out a $10, you know, here or there, it's just, we haven't found that to be effective. It's really, it needs to be a plan design kind of, you know, system. I think that's going to be the most effective. It just really is. We have seen some incentives work, but for the most part, it really is a plan design type of steerage that we think is, and that is really what we're looking at for 2021.
Okay.
I know it's probably not the answer anybody wants, because you'd love to just be able to incent people and see them do the right thing. And actually the most effective thing that we have is if we give them a 6-pack of beer.
that might work for a lot of people, right? Oh, thank you, Natalie. Candace, we had a question come in. How much disruption do you expect to see, specifically, for example, with your narrow network? And as you think about that disruption, both positive and negative, has there been pushback from employees on needing to change providers?
Well, we did look at when we added the narrow network. Before we added it, we looked at, especially in the West Lafayette campus, we have two large systems. One is in the narrow network and one is not. And when we looked at our membership, about half were in both in this area. And so we knew, a good portion of our population was already going to benefit just in us adding it, because they were already already using that provider system. And the others, and I think that's why we decided to make it, added it to all of our medical plans and made it that 3-tier. And so that in-network benefit from 19 to 20 actually did not change. And so they weren't worse off if they chose to stay within the other network or wherever they were going and not move to the narrow network. They weren't worse off, but they would be benefited if they chose to change. And so it just became an education piece. Our focus has really just been find a primary care provider, develop that relationship, because we know that that is a key piece of being healthy long-term. And so we didn't necessarily want to split that up and really get to a choice issue there if they didn't feel comfortable doing that.
Makes sense. So Phil, talking about these, implementing new solutions, disrupting the current healthcare model, from your CEO perspective, kind of what's your key takeaway from the experience of implementing a new solution? You mentioned when you were talking earlier, you were maybe a little hesitant to do that at the beginning. So what's your key takeaway for our audience?
Is that we should do it. I mean, we should disrupt as much as we can. We should try new things. And I think one of the learnings from disrupting and trying new things is the acceptance we were surprised to have from our employee population for what we were trying to do. We have been trying new things every year. It's common that when we do open enrollment, we are telling our employees about a new program or a new benefit that we're adopting, and they are overwhelmingly accepted. Our employees over the years have come to trust us to do what is right for them and the company. And so, I guess the takeaway would be, adopt that philosophy that your business is healthcare and you need to be actively engaged in it, and continue to try new things to provide better care for our employee population and manage those costs.
We had some other questions coming in. And one of the questions I wanted to open it up to any of our panelists. For those of you that were on this morning when talking about RAND 3.0, kind of what's your reaction to the data? And how do you think you're going to use that as well going forward from the employer perspective?
I can try. We will use the RAND data in helping us create direct contracts with healthcare providers, trying to do either multiple of Medicare or just a bundled price. But I guess another takeaway from the RAND study is, to me, it emphasizes what's so wrong with our system. In the RAND study, we would be happy if we were at 2 times Medicare. Now, if we were buying trucks, we would not be happy that we paid twice what the largest purchaser of trucks paid. That would be irritating. But with medical services, we think it's great stuff that it's 2 times the largest purchaser. It also shows why, as many of the other panelists have talked about, why the fee-for-service-based model is broke. That's what the Medicare is based on, is fee-for-service. We don't want to buy MRIs and knee repairs. We want to buy health, and there's the disconnect. We're measuring services. We're not measuring health.
Excellent point. Candace, what are your thoughts on?
Yeah, I mean, I would reiterate what Phil said. The only other thing I would say in regards to our reaction is, you know, it helps to reinforce and justify what us and many employers already knew. We've been looking at our data for years before Rand did this study, but it was only our own claims, and so only our information, and so we knew things were didn't feel right. We knew we were spending more and more. We knew we were spending different amounts for the same things at different systems. And so the RAND just put some strength behind that, you know, and we'll of course keep using it as backup and dig into it. But yeah, that's always been our reaction is, yes, of course, this is exactly what we knew was happening.
And I'm not sure how much time we have left, but here's another question for our panel. You know, how unique do you think it is for your organizations to drive to reduce employer healthcare costs? Are you talking to other companies and colleagues that share your focus on this? I think the answer is absolutely yes for any of our organizations. But wanted to get your opinion on that, and probably a plug too for the forum. I mean, I think that's where employers are coming together to share information and talk about how can we work on these issues together, or, you know, what strategies are others using, but wanted to get the panel to kind of weigh in on that.
Candace, you want to take that one?
Sure. So, I mean, I think you've said it all, Kristen. I mean, meeting with other employers of various sizes, you know, small employers, large employers, you know, within Purdue's system, we're very large, but we have 3 campuses that have unique needs. And then of course we have our extension folks are all throughout the state. And so how do we take what other employers, large or small, have done, and how does that work for Purdue or not work for Purdue? What have been the learning lessons? You know, not to mention when we come together and work on bigger things like policy and legislation. So, you know, yes, we're constantly comparing and trying to figure out what is next and what works or what doesn't work.
Phil, what do you hear from CEOs?
Yeah, well, a lot of what we hear is that this isn't a top priority. It's just, you know, write the check or, you know, do the program of the day. But to your point, Christian, I think it is important for we as employers to share not just best practices and ideas, but also to collectively put pressure on the system to change. You know, I think there's an opportunity for that. I think of the system as kind of a villainous system, you know, robbing wealth from us and our employees. But it's a villainous system with no villains. You know, we've heard from the healthcare providers and the healthcare system people today, they want change as well. They're very good people who want to improve health. They want to provide more efficient services at lower cost. But the system right now isn't structured that way. And unless we as employers collectively put pressure on the system to change, it won't change. It will perpetuate and stay as it is. So a great point, Christian. I think we as employers have to share ideas like we're doing today, be part of the employers forum, and pressure the system to be more responsive to our employees and us.
Excellent. Thank you. Thank you all for participating today, for sharing not only what you're doing now, but I think both of you shared kind of looking ahead, and that's important as well. Thank you for participating in our employer panel. And Gloria, I will turn it back over to you.